The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBRS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Myriad Oncology and from Solventum Prevena Therapy.
Myriad Oncology provides a portfolio of advanced genetic and tumor genomic testing solutions, including risk assessment, screening, tools to aid treatment guidance, and survivorship planning. The Myriad Oncology offering is designed to meet the unique needs of oncology specialists and their patients across each step in the patient care continuum.
To learn more, visit myriad.com/oncology.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts.
On this episode of The Next Breast Thing,
the second part of our two-part episode on the impact and opportunity of AI for breast surgery.
we're shifting to the future of AI in breast surgery.
Wouldn't it be truly amazing if we could predict who needed more regular breast? And this is all right at our fingertips. We're not far away.
What is the one issue you would want AI to solve or to do better?
Let me give you a real-world example of where we're making a big difference. Can we use AI to help determine which patients get supplemental screening? This is where I think the combination of good doctor and good AI are going to help us with better outcomes, but one alone.
Does AI need to go through a clinical trial?
Does the FDA oversee this, and are they at?
If I'm never looking at that mammogram, who's responsible for the quality of that? Wouldn't it be amazing if we had AI that could tell women wherever they are in the world, you really don't have breast cancer?
I get the sense that we're just holding back the floodgates, that medicine has been really slow to adopt.
I think you're fear-mongering.
This is Carla,
Ellie,
Michael,
Susie,
And Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.
Welcome to the second part of our two-part episode on the impact and opportunity of AI for breast surgeons. As you may remember, last time our conversation focused on the present state of AI in our daily practices as breast surgeons, as breast imagers, and in daily life.
But in this episode, we're shifting to the future of AI in breast surgery. The tools, ethics, guardrails, the required skills, and all that we might expect as AI continues to evolve.
With us today is Dr. David Gruen. As you'll remember, David is the former IBM Watson Health Chief Medical Officer, specializing in women's imaging and body imaging. He lectures frequently on healthcare technology, including artificial intelligence in healthcare. David has also lectured and published extensively on breast care, AI, and was the first radiologist in the country to become a program inspector for the National Accreditation Program for Breast Centers. You know that is NAPBC. David, welcome to the Next Breast Thing podcast, and thank you once again for being with us for part 2 of this topic.
Thanks a lot for having me back. Let's see where this takes us.
So David, today we really want to gaze into the crystal ball and stare out to the horizon and see where AI can really lead. For instance, how will this shape the future of medicine? How will it shape what we do as breast surgeons, what you do as a breast imager? Where should we start?
This is an incredibly exciting topic, an incredibly exciting time to be a doctor and a patient. We really are at what has been referred to as kind of a Promethean moment, a total transformation in the way we think about healthcare. And what we're able to do or will be able to do is truly put an individual patient, their individual needs, medical conditions, family history, their genetics, everything that makes them up, into a plan to make sure that they get the right care. We're not there yet, but wouldn't it be truly amazing if we could predict who needed more regular breast screening, but for example, may never need a colonoscopy because of who they are? They're never going to get colon cancer. Or the opposite is true. Maybe that we need to focus on their carotid arteries because their biggest risk is atherosclerotic cardiovascular disease and cancer, never going to get it. And so this era of personalized medicine, and I think that's the way to think of the power of AI, as personalizing care at every aspect, is the power of AI. It's personalizing it upstream. Prediction of who's going to get what diseases in their lifetime, how we can help people live longer, healthier, fuller lives without medications, with the right medications, giving them the right antihypertensive medicine or the right antidepressant the first time, getting them the right operation the first time, biopsying the right things at the right time for the right patients. And the sky's the limit. It's only our imaginations to solve these problems, and AI is going to provide that personalized level of data to do this in our lifetimes.
So I always say, if you're going to dream, dream big. And it sounds like that's big. How much of that is a reality in the next 5 years?
Some of it really is, Susan. To digress a minute, the vision of our organizations, the COC and the NAPBC, is to bring together multiple specialties on behalf of the patient to help them get better, more integrated, comprehensive, data-driven care. If we think about using really data to do that, how do we help a woman at every step of her lifetime with her breast care? How do we provide optimal screening based on her individual true risk assessment, not based on big data? And the best that most of the current risk models do is look at big data. If we can really personalize that risk assessment to know when she needs screening, how best to screen her, whether to get supplemental screening, boy, we've hit a home run for that woman. If we know when we need to biopsy, when we need to watch, if she develops breast cancer, we can personalize her treatment so she benefits from the right chemotherapy at the right time. We don't have to wait a cycle to find out whether she's responded to neoadjuvant. We can predict in advance what the optimal treatment is going to be for her. Because let's face it, we're not going to prevent breast cancer. But if we can get people the right treatment at the right time and not wait, boy, again, we're hitting a home run. And then if we can combine some of the imaging analytics, not just the macroscopic imaging that we see on a daily basis with mammography, but under a microscope, the molecular level of imaging, coalescing pathology and radiology to really personalize this disease. And breast cancer is not unique. It's the same is true for any other disease we're dealing with. How do we personalize treatment for lung disease or thyroid disease or pancreatic disease or ovarian cysts for that matter, and really optimize a patient's care? And this is all right at our fingertips. We're not far away.
That's so exciting. So Carla, question for you. If you had a magic wand in dealing with patient care for breast imaging, you only get one issue. What is the one issue you would want AI in general to solve or to do better than we're doing today?
It would be over screening and over treatment or biopsy. So sort of finding the right screening program. We talk a lot about high-risk patients and patients who need MRIs in addition to mammograms, but we never talk about the patient who maybe doesn't need a mammogram until she's 50 or maybe can have mammograms every couple of years. And so I think finding that right prediction model for the right screening program for the right patient.
Carl, I couldn't agree more. The issue of how we personalize risk assessment and management is something we have a huge opportunity to improve upon. To me, I think having women have unnecessary imaging for things that are clearly benign makes me crazy. It's hard to explain to a woman why she needs to be on a 6-month bandwagon for the rest of her life, because every time she comes back at a 6-month interval, we find something else and we make everybody crazy.
I would agree with that.
And it makes you crazy because you have to explain to them why the radiologist is hallucinating. And some of it's medical legal, and some of it's we just don't know what to do with the things we find. We find them and we don't want to ignore them. And so we bring them back for 6 months or we biopsy them, even though we know in our heart of hearts these don't look like breast cancer. But let me give you a real world example of where we're making a big difference. The DENSE trial looked at women with very dense breasts who got MRI, and we know the mammography finds on average 3 to 5 breast cancers per 1,000. Well, the DENSE trial identified 16 plus breast cancers per 1,000 women, which led the European Society of Breast Imaging to recommend that all women with dense breasts get supplemental screening MRI every other year. Well, clearly we're not doing that yet in this country. And I say yet because we need to do a much better job at identifying who gets supplemental screening. So here's a question that's actually being looked at is, can we use AI to help determine which patients get supplemental screening MRI? And so Screen Trust MRI used artificial intelligence to score each mammogram, and they triaged women and whether or not they got advanced breast cancer or didn't get breast cancer. And the AI method was nearly 4 times more efficient in terms of cancers detected per 1,000 MRI examinations when they triaged these women. So the highest risk women had 64 cancers per 1,000, and the lowest risk had, the average risk women had 16 cancers per 1,000. So we can identify those with AI who benefit from screening MRI and triage them till you need it or you don't. And the explainability, and this is really cool, they used 3 components when analyzing it. They used underlying risk, potential masking, and AI to look for suspicious signs on mammography of cancer. And when they pulled those 3 together, they came up with this Screen Trust MRI protocol that helped triage women at high risk to MRI. So if we can't do it on all women, we can triage women today to know who is at increased risk and needs supplemental screening. So I think that's a nice example of where we can use AI to personalize medicine to get women the right test at the right time. And just because you have dense breast doesn't mean you're going to get breast cancer. But some women are at increased risk. We got to help them get the right test today.
David, you'd said, is the radiologist hallucinating? And I know that's a term in AI. It hallucinates. Can you explain that a little bit more?
Sure. When we talk about hallucination, we're typically thinking about generative AI, which is language-driven AI. And let me give you a nice example of that. There's a really robust AI solution that's actually in pretty widespread use that many practices use that listens to a radiologist's report and then automatically generates the conclusion. There are some good studies that show that it actually saves us time. So when I go through my whole CT report, it then says finding 1, multiple liver masses suspicious for metastases. Finding 2, non-obstructing left renal calculus. Finding 3, atherosclerotic disease, below aortic aneurysm. And we train it. It's very personalized to sound like us, and it saves us time. And it's more thorough. We may forget things in our interpretation if we're dictating. It's a really good program. But here's the problem. It hallucinates. So if I describe in the body of my report, stable 2-centimeter left adrenal nodule, what it may say, the conclusion is stable 2-centimeter left adrenal adenoma. Now, I've never said that. AI is hallucinating that this nodule is an adenoma based on whatever it's calling, and it's making it up. Or it may say stable 2-centimeter left adrenal adenoma, follow-up in 6 months is recommended. Again, it's hallucinating a conclusion that I'm not giving it. And the problem is that unless I'm reading extremely carefully, those hallucinogenic comments make sense. Now, we have to be really careful with AI because one of the huge opportunities is to help guide patient care. Give the patient this chemotherapy, not that chemotherapy. Do an axillary lymph node dissection, don't do it. High risk of lymphedema, not high risk of lymphedema. And the list goes on. Biopsy this, do a quadrantectomy, do whatever you're going to do. The findings that AI is recognizing will generate an action. If the data that it's culling is wrong and its conclusion is wrong, we may make decisions for patients that really aren't the right decision. So we need to be monitoring this. A family practitioner shouldn't be administering chemo just because AI says, give them Arimidex. They need to know that this is the right treatment for the right patient and it's data-driven, and maybe the dose has changed or the combination has changed or the order or the frequency, but it really needs to make sense to the person prescribing the treatment. You, the breast surgeon, are not going to ignore a thickened round lymph node in a patient with invasive breast cancer because AI says, oh yeah, the patient has lupus. You're still going to go after that suspicious node because you have good judgment not to. But a general surgeon doing occasional surgery might not know to ignore AI in this case. And so this is where I think the combination of good doctor and good AI are going to help us with better outcomes, but one alone isn't going to. You may recall that I showed a graphic at that talk a couple of years ago of a cow hiding behind a silo. And I love this to remind people. The AI showed that the cow was appropriately 1.5 meters tall and 9 meters wide because it didn't know that it was actually 2 cows. So we need to do it together.
I work in an academic health center. I work on a lot of clinical trials. We do a lot of clinical trials to see what chemotherapy regimens work for different types of cancer. We work with genomic tests. We know there have been a lot of trials that have told us that these things work or don't work or help us. I get really excited talking about AI and talking about the right chemotherapy for the right patient at the right time, or maybe the right amount of endocrine therapy for the right amount of time for a patient. But all of this stuff obviously takes data, and we've talked about that. But I'm used to taking data and then carrying out clinical trials, seeing what those results look like. So does AI need to go through a clinical trial? Some of the radiology stuff you talked about maybe doesn't, but when we talk about treatment recommendations, how are we going to carry these out without rigorous trials?
So the algorithms do go through trials, Carla, before they're available. So anything that gets FDA approval that I've looked at in the imaging arena, for example, has gone through rigorous clinical trials. How we adopt it and when we adopt it's on us, but we're not adopting technology for widespread use that hasn't gone through it. I don't think AI is going to make up protocols. What it's going to do is call information that you may not have thought of to bring data to the forefront that may change what you do because it can provide data and information that just is beyond your realm. That's the power of AI, is to bring things to you that you may not have thought of. Now, whether you use it or don't use it is up to you. But think about the general oncologist who sees everything, doesn't just focus on breast. And they haven't kept up on what was at San Antonio or Miami Breast last month, and they don't know that actually optimal spacing for chemotherapy is now every 10 days as opposed to every 7 days. And you skip the 5-FU on the 3rd and the 5th dose. There's a lot of crazy things that just can't be on every doctor's radar, but can have a big outcome. They can then say, based on this, your outcome's better, your complication rate is lower, your long-term survival free is better. And that's where AI is going to help us. You're not making things up, but you have to know to trust it.
Does the FDA oversee this, and are they equipped to oversee this?
The FDA does, in theory, oversee medical devices and whether they get approved, and AI is a medical device generally. Mm-hmm. So the answer is yes, the FDA has to approve devices before they're used in clinical practice for safety and efficacy. Whether the FDA is able to do that, probably not, and that's not a political observation. It's a fact that the technology is moving much faster than the scientists at the FDA can handle. Think about a chest x-ray, something we see every day, and the average radiologist can look at a chest x-ray in about 2 minutes and know whether it's wrong or not wrong, or whether there's pneumonia or congestive failure, or whether there's a pneumothorax. Each of those things are individual algorithms. So there's an algorithm for lung nodules, and an algorithm for rib fractures, and an algorithm for congestive heart failure, and cardiomegaly, and devices, and ET2 placement, and the list is really long. But for the computer to assimilate all that, and for a radiologist to wait for all of that, and to check all of that, takes way, 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 way longer than it takes me to interpret a chest x-ray. We have not adopted widespread AI for the most common test we do, which is the chest x-ray, for just that reason. There's something called foundational models that are actually assimilating all of this data in a highly accurate way and saying, you know what? These 20% of chest x-rays are completely normal. We've looked at 180 different things, and there's no abnormality. And the truth is they're better than radiologists. Well, the FDA doesn't know how to approve those. If AI gets it wrong, who's responsible? So we're not yet ready to have AI look at that. But wouldn't it be amazing for me if 20% of chest x-rays didn't have to be looked at with a high degree of confidence? And the list goes on. Most Pap smears are not looked at by doctors anymore, right? They're looked at by automated technology looking for dark blue cells, because dark blue cells can be cervical dysplasia or cancer. And if there's only pink, doesn't get looked at by a cytologist. EKGs are not looked at by most cardiologists. They're automatically screened. Well, the truth is that AI probably could screen out with great accuracy 10% of mammograms. Totally normal, no breast cancer. We don't need AI we don't need CAT for it. 20% of chest x-rays. And the list goes on. Thyroid ultrasounds. A lot of what I do could be screened out and never bothered, leaving me to practice medicine. Unfortunately, one, we radiologists don't want to give up those easy RVUs. And two, we as a society don't know how to handle the risk, the oversight, the management. If I'm never looking at that mammogram, who's responsible for the quality of that mammogram? Who's responsible for the interpretation? Who's responsible to make sure there's enough freaking pectoral muscle on that and that the tech's actually doing a good job if I'm not looking at it? So we're not ready, even though these foundation models, by the data, are doing as well or better than I do.
So if we are in the next few years at the point where a company is willing to accept the risk, meaning the malpractice risk, where that mammogram is 100% normal by their AI model. And if it's 10% of all screening mammograms, 15%, whatever, the number will be lower than if you were reading it because they're building in that, well, we're not 100% sure. But for the ones that they are 100% sure of, that your name does not go on because you never see it. But when that imaging company or software AI company says, we will accept that risk, that is how certain we are. How far off are we from that?
That is a great question that I can't answer. We as a US-based industry are extremely risk averse because, as they said at that meeting a couple of years ago, there are these creatures called lawyers. And I think we're not ready for autonomous AI in this country at all. On the other hand, if we're thinking about really improving population health and addressing disparities, there are parts of the world where there are no people to look at chest x-rays for tuberculosis or for lung cancer or malaria or to screen women for breast cancer. And yet the technology is there. So we can install a mammogram and wouldn't be amazing, or an ultrasound machine for that matter, wouldn't it be amazing if we had AI that could tell women wherever they are in the world, you really don't have breast cancer. And we forget about this medical legal risk, or you need to make that 200-mile trip wherever you are in the world to the city to get care because you have something that's really worrisome. We're going to have a huge impact on global health. And so maybe the US is lagging, or maybe it's appropriately lagging by our own incredible attention to safety and security and risk assessment. And somewhere there's a happy medium, but there are not enough breast surgeons to go around. There's certainly not enough radiologists to go around. People are delaying their care, and we're seeing late-stage disease. We need to do better. We're not acting like a first-world country when it comes to healthcare.
And we know that the physician shortage is increasing. We're not even at the tipping point yet, but statistics will say we're not that far off. We really are getting to the point where there are not enough breast imagers or radiologists to read all of the screening mammograms that we want our patients and all of us to get. So we may be forced to that point because there's just not enough people to read the imaging tests that are being done.
Or with it, we can read significantly faster and more confidently and have more people do it on a more comfortable level and recall fewer people and spend less time doing unnecessary biopsies and under recalls and unnecessary recalls, as we talked about, because our accuracy is better. And AI can enable us to be more efficient in what we do. And it also works, Susan, on the back end, which is also really exciting. If you think about triaging out the normals, at the point of care, if we could triage the abnormals or the women at increased risk and find those women and say, you know what, you're really at high risk. I want the radiologist to look while you're here. Or you're at really high risk. I want you to talk to someone about a high risk supplemental screening program might be for you so that you don't miss your next study because there's something there. We're going to save a lot of lives.
I get the sense that we're just holding back the floodgates, that medicine has been really slow to adopt and all of this pressure is building. And when it opens, it's going to open in a hurry. And,
general medicine is slow to
of course it is.
New technology.
But you look at adoption and you go, okay, well, the people that do pattern recognition, like radiologists or pathologists, those guys are gone. And then you say, okay, well, the next in line is going to be the diagnostician. And you go, well, we're proceduralists, so we're not going to get affected. But I've seen a lot of this stuff where you could take an MRI, overlay it into a robot, set the margins, and you're locked out of taking anything wider or anything closer to the tumor. I don't think that's that far away. When the gates open up, I think all of us are going to be affected. I don't think the surgeons are going to be unaffected by this. And I don't think it's a bad thing, but we just kind of assume and sort of whistle past the graveyard that none of this is going to happen in our lifetime. And I think it will.
I think you're fear-mongering.
I'm not fear-mongering. I just said get ready.
You skipped over getting better care and enhancing what we do to, we're out of a job. I don't understand.
I'm with you, but I'm being self-serving here. We are breast surgeons, and how will this affect us? And I think it'll be better for the patient in some ways, but if we're not ready for it when it comes, I don't know how we handle that.
You are the poster child for good medicine because you figured out how to de-escalate the axilla and to de-escalate from mastectomy to breast conservation. And you've expanded who can get breast conservation with oncoplastics. So you've evolved in the interest of patient care, even if it's at the expense of the procedures you might do.
Except we did it over decades. And I think this thing is going to happen in years. And it's easier to adopt something that sort of trickles out than something that comes at you full force. Again, I'm not afraid of it. I'm just sort of bracing for it because I think when the change starts, it's going to be at a head-spinning rate.
Well, and I think we should zero fear of us being out of work because of AI. I really...
Well, I'm not think we're going to be out of work, but I think it's going to be like flying an airplane where the pilot sits there and the plane flies itself. And in case something really goes wrong, maybe we're running 3 rooms at a time while the robots work and we oversee that. I don't know. There's going to be a need for us, clearly, but how we adapt to that is going to be big.
Isn't that a lot of how they do orthopedic surgeries these days when they do knee replacements and hip replacements? I mean, they're doing image-guided robotic surgeries. I would imagine it's very similar. And I think the other thing I want to just mention briefly, Michael, is I think the American Society of Breast Surgeons is trying to kind of tackle some of these questions, right? I mean, we're obviously talking about this now, and we're also trying to create a group to say, what is AI? What's on the horizon for breast surgery? Let's start talking about this so we are prepared for whatever is ahead of us.
Yeah, I mean, I think this is a case of adopting current technology, and you will all do it. It's going to make your patients have better outcomes, and you're going to lead this. Think about what radiologists have gone through, right? We went overnight, basically, from film to digital when PACS came out, and industries went away. The whole darkroom industry went away. And then we went overnight to voice recognition from a tape recorder, and the whole transcription industry went away. At the end of the day, what's that mean? Our patients and our doctors get faster results. So we've had to adopt, and we've all had to adopt. I think this is just the next stage in evolution. And yeah, if you could know that you only had to do one operation significantly more of the time, your patients would be happier and you'd be happier. I mean, how many breast surgeons have I heard complain that they don't have enough operating time? They're either seeing the wrong patients or doing too much stuff they don't need to do or whatever it is. Let's get you the right operation in the right time, get you to take care of patients the way you want to.
I think it's the changing landscape, Michael, rather than things going away. I think things just change. And I think that's part of life and part of evolution. And the key is to keep up with it and almost get ahead of it rather than running up to catch up.
It is a situation though where I think that we have usually adopted change more slowly than we're going to encounter with this. I think the change is going to be at a breakneck speed, and you got to brace yourself for that.
I think the change in the medical world isn't slowed down by us adopting it. Data sharing tends to slow us down, and we haven't even touched too much on reimbursement or financing some of these things. I hope those things don't slow us down too much, but I feel like those are the things that tend to slow us down in medicine, and not surgeons and APPs and nurses and everybody.
So much care right now is delivered by non-physicians. And I think I'm going to go on a tangent here and say that if it were my mom, I would prefer to have her seen by any one of you than any of your non-physician colleagues who are seeing many more patients for things beyond their expertise. There are not enough of us to go around, and I think there is definitely a role for ancillary providers. But I think if we can use data and insight and augmented intelligence as the other words for AI to help those who have not done 4 years of medical school and 5 years of residency and 2 years of fellowship and 20 years of breast surgery under their belt to teach them to make good decisions, well, then let's bring that technology and data and information to help bring care up to those who can't provide it at the level that we can.
David, do you ever see a point where there is a digital follow-up? Because right now we serve as a filter to AI, whatever we've researched or whatever else. Do you ever see a time where a patient's going to do follow-up and never see a human being? Their data is put in and has a virtual talk with the machine?
I can imagine it probably will. It's touched every other aspect of our lives, right? Would you like to speak to the American Express digital assistant and you can cancel a card and stop payment and order things? Why wouldn't a chatbot be able to talk about complications of medications or look into the camera on your computer and I'm going to look at your retina or whatever it's going to be? It's scary, but I hope not.
But it goes back to your point of I would rather this family member of mine see somebody that has more expertise. Could we digitally have more expertise?
That's what we're talking about. We're talking about augmenting what we do, pulling data beyond our ability to synthesize into our realm to help provide better insights, but not unsupervised completely. I mean, I wouldn't want a bot to change my medication. But on the other hand, we're talking about other fields. You mentioned orthopedics. It's a great example. How many of us know someone who's on an antidepressant? Well, how do most people put people on antidepressants? Well, what is the local drug rep delivered? Because they certainly don't know that Prozac is going to have a better outcome than Wellbutrin is going to have a better outcome in the first month than something else. And so a lot of it's shotgun medicine. What if data analytics could look and say, you know what, based on your heritage, your genes, your specific symptoms, your XYZ, you're going to do really well on Zoloft, but not on Paxil. Let's start you on the right antidepressant the first time with the fewest side effects. That's the kind of chatbotting where data is going to help us across medicine.
This has just been so enlightening. And one of the things that I truly believe in is that we have to learn something every day. It's almost a mindset to say, okay, at the end of the day, I have to think about what did I learn today? And I've learned so much. Michael, tell us what you learned.
We're doomed. I've seen Terminator and we're doomed. No, I think I have learned that AI is just going to make it better. It's going to make it better for us to practice. It's going to make it better for the patients. I think outcomes are going to be better. I think more patients are going to be taken care of at a higher level. And it's just going to be how do we adopt that safely and get that out to our patients?
I think that you hit so many of those points and stated in such a great way. Carla, your takeaway?
I think it's going to help those of us who are practicing at a high level, but I think it's also going to help people who are practicing, who are a few years in training, people who are in more rural areas. I mean, I just think it's going to help lift the bar for everybody. I guess the other point I was remembering now is that I think the data behind it is pretty good. And so we worry about some of the legal implications. We worry about our patients. And I think we as providers want to make sure that what we're saying and asking our patients to do is well supported. And there's a lot of stuff out there, but knowing that a lot of the stuff is pretty robust is important.
David, these 2 episodes have been so eye-opening and insightful. And I have to say, whenever I speak to you about AI or about breast imaging, I just learn so much. You delivered a keynote address at American Society of Breast Surgeons a few years ago, and I have gone back to watch that talk because there was so much information packed into it. So I encourage all of our listeners, it's on the ASBRS website. Go back and listen to it. I promise you, not only is it inspiring because David's a phenomenal speaker, but it is so educational. And some of what you said there has already come true. It was just so spot on, as was everything that you told us on this 2-part series. So before we go, do you have any final thoughts to share with our community of breast surgeons and anyone who really takes care of breast patients?
Thank you, Susan, and to Michael and Carla. It's been great to be with you. These 2 episodes have reminded me why it's so special to take care of breast care patients. And a big part of that is that we have figured out that when we work across specialties, we do a better job for our patients. And working with surgeons and radiologists together and pathologists who understand the disease and reconstructive surgeons who know how to put people back together and make them feel whole, and therapists and counselors and navigators and nutritionists and everybody in the pipeline, people who study lymphedema, people who study nutrition, and the oncologists, of course, who go along with it. We're stronger together. And our patients are better because of us being together and not worrying about turf wars, but really just putting patients at the center of care. And when we have conversations like this and we think about what are the common problems we can still solve every single day to improve outcomes and how we can leverage technology to solve those problems, well, that gives me a charge and gives me hope that one day we'll know which lymph nodes to biopsy and which patients can get conservation and which patients will get lymphedema or have their graft break down or need extra biopsies. Or, to your point earlier, Carla, don't need supplemental screening or need more regular supplemental screening. And we're going to save a lot of money and have more personalized medicine and better outcomes. And I think that's why we're all here.
There's so much more that I would love to talk to you about. All of breast imaging. I know I speak for Michael and Carla. We all have so many questions about CEM and MR and ultrasound and dense breast and risk-appropriate screening. So your phone may ring again, so be prepared. I think we're going to have you back. But it's really been a pleasure having you with us on The Next Breast Thing. And we will put the link to David Gruen's talk in the show notes, so be sure to look out for that. To our listeners throughout the entire breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.